Please start. We are live.
Namaskar and good evening, everyone. A very warm welcome on day two of webinar on clinical pathways in common cancer care. With immense pleasure, I would like to invite the webinar convener, Dr. Devesh Goyal, Senior Consultant Medical Oncology, Fortis Hospital, Jaipur, for the welcome and introductory note. Over to you, sir.
Yeah. So thank you, Pooja, and thank you, Horizon, for this support. And today is the day two of this webinar session of clinical pathways in common cancer care. As we all know, that yesterday we discussed about this gynec and GI cancer, and today we discussed on the lung as well as breast and some part of GI cancer. So we will discuss one by one today. So without wasting the time, I invite the first speaker, starting speaker of this webinar of today. Topic, so Harmony 6. So this was abstract was presented. Ivonescimab plus chemo versus Tisli plus chemo. So I invite Dr. Sachet Saxena, who is from Udaipur GBH American Hospital. So over to you, Dr. Sachet.
Thank you, sir.
Yeah, welcome.
Can we start sharing the slides, please?
Yeah.
Sir, should I share or you will be sharing?
Ma'am,
Please, you
kindly
share.
share.
Okay.
Yeah, full screen.
Sir, is it visible?
Yes.
Yes, sir. Please.
Good evening, everyone. Thank you, Devesh, sir, once again for giving me this platform and a wonderful academic feast for all of us. I will be discussing about the Harmony 6 trial, that was ivonescimab plus chemotherapy versus trastuzumab plus chemotherapy in previously untreated advanced squamous non-small cell lung cancer. Next slide, please. Yeah, next slide, please. Yeah. So, what was the background of this trial? Actually, we all know that clinician medical oncologists fear of giving VEGF-directed therapies, especially bevacizumab in squamous cell cancers, lung cancers. We have a lot of plethoras of and a lot of options in adenocarcinoma lung, but we have limited number of drugs in squamous cell lung cancers. And the previous historic trials of bevacizumab in squamous cell lung cancers had episodes of fatal hemorrhages. That is why bevacizumab is no more used in squamous cell lung cancers. So this is what is ivonescimab. It is a bispecific antibody that inhibits both PDL1 as well as VEGF. So what was the background for the patient with advanced squamous non-small cell lung cancers? PDL1 inhibitor plus chemotherapy is an established first-line regimen. And however, few studies were powered for OS and reported clinical significant improvement. Harmony 6 is a randomized double-blind phase 3 study of ivonescimab plus chemotherapy versus tislelizumab plus chemotherapy in patients with squamous non-small cell lung cancers. So, in the interim analysis, it significantly improved the PFS, 11.1 versus 6.9 months. So, can the bispecific antibody-based regimen significantly improve overall survival? So, here we report the results of pre-specified OS interim analysis of Harmony 6. Next slide, please. So, what was the study design? It was a phase 3 randomized, double-blinded, parallel controlled phase 3 study in which the eligibility criteria was squamous non-small cell lung cancers, stage 3B to 4, which didn't receive any systemic therapy and had no EGFR or ALK rearrangement, and ECOG performance status of 0 and 1. The stratification factors were stage 3B, 3C versus stage 4, PDL1 TPS of more than 1% versus less than 1%. And all this population, that was around 532 patients, were randomized 1:1 to two arms. That was, one was the ivonescimab arm, in which ivonescimab was given around 20 mg per kg 3 weekly, along with paclitaxel 175 mg per meter square pacli and carbo AUC 5 for 4 cycles. And then ivonescimab was continued as maintenance of 20 mg per kg at least for 2 years. And the comparative arm received tislelizumab plus chemotherapy, same chemo backbone, up to 4 cycles, followed by tislelizumab maintenance up to 24 months. The endpoints were PFS, key secondary endpoint was OS. Next slide, please. So, what was the importance of this statistical consideration here? Because it was a superiority trial, so only one way they had to limit the false positivity. So instead of taking the alpha as 0.05, they deliberately took it 0.025. So why this was important? But and other thing was, it was acting like a gatekeeper. Why? Because only if this specified analysis of PFS was proved beneficial and it was more than 0.025, then only they could proceed to OS. So hierarchical testing was applied with PFS tested first, followed by OS at one-sided of alpha, that was 0.025. And PFS was statistically significant at interim analysis. Median PFS was 11.1 versus 6.9 months, hazard ratio of 0.6, and P was very significant, that was less than 0.001, enabling formal testing. And the pre-specified interim and OS analysis was conducted at 204 events. Yeah, next slide, please. So 532 patients were randomized. 266 were assigned to receive ivonescimab plus chemotherapy. 266 were randomized to receive tislelizumab plus chemotherapy. 266 patient received ivonescimab, and 265 patient received tislelizumab because one patient withdrew. And 24 patients were able to complete the treatment in ivonescimab arm versus 28 in tislelizumab arm. And at the final endpoint, 60 patients had treatment undergoing in ivonescimab arm, and 51 patients had treatment undergoing in the tislelizumab arm. Yeah, next slide, please. So baseline characteristics were well matched. Age, patients were nearly equally divided between less than 65 and more than 65. They were majority of patients were male. ECOG patients had majority were having ECOG 1, and majority of patients were former or current smokers. Most of the patients were of stage 4, and the worst possible scenario of treating physician giving anti-VEGF inhibitors, that is central type tumors, major blood vessel encasement, cavitary, and with prior hemoptysis history. Nearly all the patients were included in the ivonescimab arm and were equally balanced in the tislelizumab arm also. Less than one, majority of the patients were having PDL1 TPS of more than 1. And 1 to 49 were 42.1%, and more than 50 were 18.4%. And metastasis also, more than 3 metastatic size, and liver and brain mets were nearly equally matched. Yeah, next slide, please. So interim analysis was done, and overall survival was statistically significant in the ivonescimab arm. That was at 12 months, ivonescimab arm outperformed tislelizumab arm. 78.9% was the overall survival in the ivonescimab arm, and 72.2% was there in the tislelizumab arm. And at 24 months, 64.7% was there in the ivonescimab arm, and 48.6% was there in the tislelizumab arm. And hazard ratio was impressive, that was 0.66, and the p-value was significant, that was 0.0017. Yeah, next slide, please. So then they did the subgroup analysis of the overall survival. Nearly all the subgroups benefited from the ivonescimab arm, and especially the liver metastasis, brain metastasis, and more than 3 metastasis sites were benefiting from the ivonescimab arm. May it be PDL1 TPS of less than 1%, more than 1%, 1 to 49%, and more than 50%. And next slide, please. So overall survival that was done by PDL1 expression levels. So PDL1 TPS less than 1%, hazard ratio was 0.64, and we can see the graph of this ivonescimab outscoring that of tislelizumab. And PDL1 TPS more than 1% also, ivonescimab arm outperformed tislelizumab. The hazard ratio here was 0.68. Yeah, next slide, please. And within the TPS1 positivity subgroup, in 1 to 49%, also ivonescimab arm benefited as compared to that of tislelizumab. Hazard ratio was 0.67, and PDL1 more than 50%, hazard ratio was 0.64. And next slide, please. The patient went on to receive subsequent anti-acute tumor therapies, and they were able to receive systemic therapy in 95 around 35% of cases in the tislelizumab, 36% in tislelizumab, and 35% in the ivonescimab arm. Chemotherapy, immunotherapy, and targeted therapy were all given to all the patients. Yeah, next slide, please. Yeah, so treatment-related adverse events were nearly same in both the arms. Grade 3 treatment-related adverse events were more in the ivonescimab arm, 69.2 versus 58.9 in the tislelizumab arm. And serious treatment-related adverse effect were also more in the ivonescimab arm, around 41.4% versus 34.3%. But leading to discontinuation of tislelizumab, ivonescimab or tislelizumab were nearly same. That is 5.3% in ivonescimab arm and 4.5% in the tislelizumab, and leading to death were again 3.8% in the ivonescimab arm and 4.2% in the tislelizumab arm. Overall, grade 3 side effects were slightly more, but yeah, leading to death or discontinuation were nearly same. The next slide, please. So incidence of most common treatment-related adverse effect, that was more than 15%. Alopecia was more common in the ivonescimab arm. Anemia and neutropenia were nearly same, we can say, for in both the arms. And then due to the traditionally that we can say that the VEGF inhibitor related side effects, grade 3 side effects were nearly very less, and fatal side effects were very low. And proteinuria and thrombocytopenia, hypoesthesia, decreased appetite, all these side effects were there in the both the arms, probably both due to the chemotherapy. Yeah, next slide, please. So possibly VEGF-related adverse events, if we can see. So more frequently in the ivonescimab, yes, but most of them were grade 1 to 2. Hemorrhage, we can see more than grade 3 were only 2.6%. And hypertension was 3.8% as compared to tislelizumab 1.9. These are all the grade 3 effects, but all were in the manageable range and traditionally very less as feared apart from other VEGF inhibitors. Next slide, please. So what are the conclusions? Ivonescimab plus chemotherapy significantly improved overall survival in advanced squamous non-small cell lung cancers as first-line treatment as compared with tislelizumab plus chemotherapy. Median overall survival was around 27.89 months versus 23.69 months with hazard ratio of 0.66 and p-value highly significant, that is 0.0017. And ivonescimab plus chemotherapy showed comparable safety profile as compared to tislelizumab plus chemotherapy. Grade 3 treatment-related adverse effect was more, but majority were manageable, and similar rate of adverse effect leading to discontinuation or death between the two arms. So Harmony 6 supports the adoption of ivonescimab with chemotherapy as new standard of care for patients with advanced squamous non-small cell lung cancer, and a global phase 3 study, Harmony 3, is underway. Next slide. So these are the key takeaway points. So it was the first dual PD-1 and VEGF dual targeted bispecific antibody and has been approved in China for two lung indications in 2024. Ivonescimab plus chemotherapy significantly improved overall survival and previously untreated squamous cell lung cancers with tislelizumab plus chemotherapy. And Harmony 6 has met its endpoint, all key and secondary endpoints, and most importantly, had a manageable safety profile and which was consistent with prior studies. Thank you.
Yeah, thank you, Dr. Sachin. I think this is the newer molecule. I think right now, I think in India it is available or not?
I don't think so. It is available in India
I
right
think
now.
shared in few months, if it is available, then we can use in our metastatic settings of patients.
Yes, sir.
Definitely.
Because as discussed, we never used to give VEGF inhibitors in squamous cell carcinoma, and this is altogether defined new treatment paradigm in
Yeah.
squamous cell lung cancers.
Okay. Thank you, Dr. Sachin. Thank you. So for this next talk, I invite Dr. Dharampal Jakad, who is from the Tata Hospital, Sangrur. He is assistant professor. So the topic is Chrysalis. So amivantamab plus lazertinib. So over to you, Dr. Dharampal.
Thank you, sir, for this opportunity.
Yeah, welcome.
So I would request to
डॉक्टर
kindly share
थोड़ा
the
सा
slide.
थोड़ा सा अर्ली कर लीजिएगा बस है ना ये है
Yes, 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 sir. Okay. I will start in within 1 minute, please.
Okay, sir.
So, Dr. Dharampal sir, good evening. Can you see the slides, sir?
Yes, slide are visible. Thank you. Thank you, sir, for giving me this opportunity.
Okay. So you just have to
So,
say next slide, and Pooja will be sharing the slides.
sure, sure,
Follow.
sure. So I will discuss the role overall survival of first line amivantamab plus lazertinib in atypical EGFR mutated advanced non-small cell lung cancer. So in EGFR atypical mutation, generally we use afatinib. This is cheaper drug, and its PFS is around 9 to 10 months. So next slide, please. So, a significant proportion of non-small cell lung cancer driven by EGFR mutation, including the exon 20 insertion and atypical mutation. Currently available therapy for atypical EGFR mutated advanced non-small are less effective compared with those for common EGFR mutation. So, afatinib is the only EGFR TKI currently approved for the atypical EGFR mutation. Has demonstrated a median OS of 19.4 months, with 95% of particularly having discontinued treatment by 2 years. So osimertinib with third generation EGFR TKI show a median PFS of 9.4 months. Discontinuation treatment by 1 year. So other EGFR TKI are currently in development of for EGFR, exon 20 insertion and atypical. So I will discuss what are these atypical mutation. So in all EGFR mutation, 80 to 90% mutation are exon 19 and L858R mutation. These are typical mutation which responded well to all of the TKI like osimertinib, gefitinib, erlotinib. But out of them, this exon 20 insertion, we all know that TKI therapy are not effective in exon 20 insertion mutation. And another atypical mutation like G719X, S786, and this L861Q. So these are 5 to 10% of all EGFR mutation. So presently we are giving only afatinib 30 mg or 40 mg OD for these kind of mutation. And osimertinib also shows some kind of activity in these atypical mutation. But otherwise, other TKI first generation and second generation are not effective in this scenario. So this is a cohort subgroup analysis of this CRISTALIS 2 trial, and I will discuss the role of what is the role of amivantamab and lazertinib in these subset of atypical mutation. Next slide, please. So we all know this mechanism of action. Amivantamab is EGFR and MET inhibitor, and Legetinib is a typically EGFR mutation. So these both complete block the EGFR mutation. Next slide, please. And also these combinations show some antibody immune activation. So we will discuss Chrysalis 2 study design and typically discuss about cohort C, which is about atypical EGFR mutation. Primary endpoint is overall response rate and secondary endpoint is the duration of response. Next slide, please. So radiographically response with first line amivantamab plus Legetinib in atypical EGFR mutated non-small cell lung cancer. So with this, we can say that median out of population, 45% was female, 57% were Asian. Most frequent EGFR mutation was G719X, A768X, and L861X. So at a median follow-up of 16.1 month, overall response rate was 57%. Median duration of response was 20.7 months, and median PFS was 19.5 months. Next slide, please. So this is the study design, dose escalation phase. We all know about the this amivantamab drug. So it's available in 350 mg vial. If a patient is less than 80 kg, we are giving 3 vial. If patient is more than 80 kg, we are giving 4 vial. Infusion reaction are very common with this drug. And they also added this oral TKI Legetinib 240 mg orally. And secondary endpoint was assessed overall survival. So in the early analysis for cohort C, OS was not established for the treatment naive population. Here we present OS outcome from the treatment naive population of Chrysalis 2 cohort C after longer follow-up. Next slide, please. So at a median follow-up 13.13 months, 20% of the patient participants were still ongoing with first-line treatment. So as per this graph, we can see that out of around 50 patients received amivantamab plus Legetinib, and cohort C treatment naive patient was amivantamab 50%. So ongoing is still 20% patient are ongoing. Next slide, please. So overall survival of median is 14.1 month. So this is for 14.1 month. This is seen with the median follow-up 13.3 month. So next slide, please. Most participants who had disease progress and discontinue first-line treatment were able to receive subsequent therapy. The most common subsequent regime included platinum-based chemotherapy containing regime. As you can say that most of 55% patients received platinum-based therapy. Next slide, please. So time on treatment, the median duration of treatment with amivantamab plus Legetinib was 13.3 months. 39% of first-line participants remained on treatment for more than 2 years. Next slide, please. So this is the graph which are showing time on treatment with atypical EGFR mutation. We have already discussed. Next slide, please, with response. And this is the graph showing partial response, stable disease, progression of disease, time on treatment with the patient who have also show TP53 mutation. Next slide, please. So overall survival versus real world cohort of atypical EGFR, a descriptive retrospective observation analysis was conducted to evaluate OS of a real world atypical EGFR mutated non-small cell cohort received a physician selected first line therapy. So we can say in amivantamab plus Legetinib, median OS was 14 months. But this physician selected EGFR, it was 15.2 months. So we can see it's significant OS was seen with this combination of amivantamab plus Legetinib. Next slide, please. So safety profile, we all know that the side effect of amivantamab plus Legetinib, most adverse events were grade 1 or 2. Chrysalis 2 was conducted prior to subcutaneous amivantamab approval as well as Cocoon and Skippy. Therefore, participants received IV amivantamab and did not receive enhanced prophylaxis for dermatological adverse event and IRRs. Next slide, please. So this is the conclusion of my slide. The single arm study of amivantamab plus lazertinib in first-line atypical EGFR mutated advanced non-small cell lung cancer demonstrate a clinically meaningful median OS of around 3.5 years. Response were durable regardless of demographic baseline, tumor mutation, and disease characteristic. With a longer follow-up, the safety profile of IV amivantamab plus lazertinib was consistent with prior reports with no new safety signal. So this amivantamab plus lazertinib-based first-line treatment has now had durable survival in both common and atypical EGFR mutated advanced non-small cell lung cancer. Thank you.
So thank you, Dr. Dharampal. So I think this drug nowadays only amivantamab is available. I think lazertinib is not available.
Yes, sir. This oral TKI are still not available, but this amivantamab is available.
Okay, so can we use afatinib along with this amivantamab?
No, sir. If in our setup we are only giving afatinib, sir.
Okay.
Amivantamab I have given in my DEM residency at Tata Hospital, Mumbai.
So okay, thank you, Dr. Dharampal, for this talk. And for
Thank
next
you.
talk, I invite Dr. Sajna Chaudhary, she is from Jaipur, and presented is the Laborto 432 abstract. So over to you, Dr. Sajna. Kindly finish in 5 minutes. I think we are already late. Unmute yourself. Unmute. You are not audible. I think. Pooja, stop this, Dr. Dharampal.
Yes, sir.
No.
Ma'am, you will be sharing or I will share your slides?
Sharing.
Okay, ma'am. Okay.
Our slides are visible?
No.
No, ma'am. No, ma'am.
Just hold on.
डॉक्टर साहब थोड़ा सा 5 मिनट में कंप्लीट कीजिएगा एक बार ना.
Sorry, sir.
नहीं कोई इशू नहीं है, आप 5 मिनट में कंप्लीट कीजिएगा.
So there is some.
We can share from. Oh yeah.
Is it visible? Slides are?
Yeah, slides are visible.
Okay.
Yeah.
Thank you, sir. First of all, thank you, sir, for giving me this opportunity.
Yeah, thank you.
So today I'm here to discuss the ESCO 26 data of this study. Just a second. Again, slides are not visible.
I think here are visible.
Okay, sir. ESCO 26 data of this study, event-free survival with adjuvant selpercatinib in stage 1B, 2, 3, RAD fusion positive non-small cell lung carcinoma. That is primary results of the phase 3 Liberto 432 trial. So the targeted therapy is a mainstay of treatment in oncogene-driven non-small cell lung carcinoma, where immunotherapy has shown limited activity. The adjuvant targeted therapy improves the outcome in EGFR and ALK-positive early stage non-small cell lung carcinoma that establishes a new standard of care in these patients. In randomized phase 3 Liberto 431 trial, that is for metastatic setting, selpercatinib shows in successful PFS survival that is compared to chemo plus pembrolizumab in advanced and metastatic RAD fusion positive non-small cell lung carcinoma. So, and there is no adjuvant targeted therapies approved for early stage RAD fusion positive non-small cell lung carcinoma. So adjuvant selpercatinib offers the potential to deliver comparable benefit in this patient population. So Liberto 432 is a randomized phase 3 trial investigating selpercatinib as an adjuvant therapy in patients with early stage RAD fusion positive non-small cell lung carcinoma. So the study designing, this is a global multicenter phase 3 double-blind randomized placebo-controlled study. The key eligibility criteria are histologically confirmed RAD fusion positive non-small cell stage 1B, 2, and 3A stage. And those patients have already received definitive therapy in form of surgery or radiotherapy with or without systemic adjuvant chemotherapy after definitive therapy, and there should be no disease progression or recurrence following definitive therapy. And patients are stratified by the stage either 1B or 2 to 3A, and the definitive treatment received either surgery or radiotherapy. Patients are randomized 1:1. Total sample population is 151, and the treatment of selpercatinib is given as 160 mg BD in patient with more than 50 kg weight, and in dose of 120 mg BD in less than 50 kg weight patients. And placebo is also given BD, and this is given, selpercatinib is given for 3 years or till the disease progression or recurrence or death. The primary endpoint of the study is investigator assessed EFS in primary analysis population, that is stage 2 to 3A. And the secondary endpoints are EFS by BICR in primary analysis population and EFS by investigator and BICR assessment in oral population, that is 1B to 3A, and the safety and oral survival. So this is in hierarchical testing scheme. First, primary analysis population in 2 to 3A, and then in overall population, EFS is treated, that is in 1B to 3A stage population. So the final analysis of EFS is originally planned to occur after 67 events in the primary analysis population, assuming an EFS hazard ratio of 0.5. And prior to unblinding and analysis of EFS, this assumption is re-evaluated based on the ADAURA trial with a hazard ratio 0.17 and ELENA trial of hazard ratio 0.24 outcomes, and that is further supported by the selpercatinib activity in metastatic setting in Liberto 431 trial. So the protocol amendment is revised, and the primary analysis is performed after 20 or more than 20 EFS events occur within a follow-up of 4 or more than 4-year follow-up since the first patient randomized, assuming the EFS of with hazard ratio 0.24. The sample size remains unchanged, that is 150 to 170 patient sample size. So the overall population randomized is total sample size is 151, and firstly in oral population stage, that is 1B to 3A, total sample size is 75 for selpercatinib, and then for primary analysis population, that is 2 to 3A, sample size is 54. And it is done in the 65 sites in across worldwide in 22 countries from January 22 to 25. So the baseline characteristics are well balanced in the both selpercatinib and placebo arm. The median age is about 60 years in the selpercatinib. Most of the patients are female population, that is about 63% are females, and Asian population is mainly about 61%, mainly of East Asia, and never smokers are about 68% in selpercatinib arm. And in red fusion positive, that is K5B red fusion is mainly, that is about 61% out of all red fusion, and about 46% of the selpercatinib arm is PDL1 positive, and also about 51% in the placebo arm. And all patient, about 100% patient already received definitive treatment as surgery in both arms. So when we look at the event-free survival by investigator assessment in the primary analysis population, that is 2 to 3A, red fusion positive. So at the 24-month, EFS rate is 91.5% with the selpercatinib arm and 61% with placebo with a hazard ratio of 0.17. So the primary endpoint is met, and the selpercatinib shows a statistically significant improvement in EFS. And also in the oral population, that is 1B to 3A population, there is improvement in the 24-month EFS, that is 94% versus 69.6% with a hazard ratio of 0.16. So the EFS by the BICR in the primary analysis population also, there is a hazard ratio of 0.12, and in the overall population 1B to 3A with a hazard ratio of 0.12. So the EFS by BICR are consistent with the investigator assessment in both the population. When we look at the primary analysis in all subgroups, it leads to improvement in the all subgroups, but specifically in the like female and those patients who are less than 65-year age and mainly European population and never a smoker. and of stage 3A in compared to stage 2, and those patients who have received adjuvant chemotherapy after definitive treatment shows a better hazard ratio. So when we look at the site of the progression, in selpercatinib arm, there is one local regional progression in compared to 10 in the placebo arm, and 5 patients developed distant mets in selpercatinib arm in compared to 18 patients in the placebo arm. In the when we look at the overall survival, the median follow-up is about 25 months for the selpercatinib and also for the placebo about 27 months. And 0 patients, none patient shows death in the selpercatinib arm, and 3 patients died in the placebo arm. About 16 patients of stage 2 to 3A patients are crossed over from placebo to selpercatinib following the disease recurrence in the control arm. So, and 12 of these patients remain on the selpercatinib at the data cutoff, and the 3 patients died in the patient who are crossed over from placebo to selpercatinib, and no death occurred in the selpercatinib arm. When we look at the safety overview, about 67% patients developed grade 3 or more treatment-related adverse events in the selpercatinib arm in compared to placebo, that is about 25%. And about 17% patients discontinued the selpercatinib. And dose modification is needed in the 88% of the selpercatinib arm. And there is no death occurring in the selpercatinib in compared because of this side effect. So the grade 3 of side effects of grade 3 or more are manageable with the dose modification, and the discontinuation are mostly of low grade events in the selpercatinib arm. When we look at the adverse event occurring with the selpercatinib, mainly these are LFT derangement in the form of AST or ALT increase. About 62% patient are having LFT derangement, and about 18% of these are of grade 3 or more. Another side effect with the selpercatinib observed is diarrhea, that is in about 39% patient, and bilirubin increase. Another is hypertension, about 30% patient having hypertension. Another is constipation or hyperuricemia in about 20% of the patient with selpercatinib. Another side adverse event are observed are hypersensitivity and ECG showing QT prolongation in 9% patient with the selpercatinib.
Ma'am, sorry to interrupt you. Please conclude the session.
So, selpercatinib shows a statistically significant and clinically meaningful event-free survival improvement in the patient with a RAD fusion positive NSCLC in compared to placebo with a good hazard ratio of 0.17 in stage 2 to 3A population. And there is consistent clinical benefit is observed across the all subgroups. Selpercatinib adverse event are generally consistent with the already known safety profile, and the grade 3 or more than grade 3 adverse event are managed with the dose modification. And these adverse events that lead to discontinuation are mostly of low grade events. So these results reinforce the value of comprehensive biomarker testing for the actionable driver mutation at the time of the diagnosis to inform the optimal therapeutic decision making for adjuvant treatment also. So adjuvant selpercatinib should be considered as a new standard of care in early stages of RAD fusion positive NSCLC. So takeaway points are that it improves EFS in early stages, and safety is consistent with the known safety profile, and there is a shift in the clinical practice and emphasize early and comprehensive biomarker testing. Thank you. Thank you, sir.
So, Sajna, so I think we can include these markers even in early stage cancer also. So we are doing the markers in the latest advanced stage. So this trial is also shown that we can incorporate these markers in early stage also. So
Yes,
thank you for a talk.
Thank you,
And
sir.
for this next talk, the session is the AstraZeneca sponsored session. So for this, I invite Dr. Rishabh Jain, who is a medical oncologist in Renova Cancer Hospital, RHL Jaipur, and he's giving talk on the extending benefit in the EGFR mutated non-small cell lung cancer and the power of combination. So over to you, Dr. Rishabh.
Yeah, thank you, sir. So, I think the sharing is not available to me.
No, I think Pooja, see the issues?
Sir,
Okay, I will share like this. Okay, no issues. Is it visible?
Yeah, visible.
Yeah. So thank you, Devesh sir, for giving me the opportunity to present on benefits of EGFR NSCLC, the power of combinations. So as we know, EGFR mutation positive NSCLC is very common. And the most common EGFR mutations seen are exon 19 deletions and exon 21 L858R mutations. And those are seen in around 33 to 35% patients of our population. And these are mostly those young women who are non-smokers. And when we look at the evolution of EGFR target therapies in NSCLC, we do know that we have started from gefitinib, move on to erlotinib with monotherapies, and now we are in the era of combination therapies like amivantamab plus chemotherapy or osimertinib with chemotherapy. And when we look at the survival outcomes with EGFR tyrosine kinase inhibitors, we do see that osimertinib is the first EGFR TKI to demonstrate a significant overall survival benefit in EGFR metastatic NSCLC patients via the FLORA trial. So the need arises, if osimertinib monotherapy was so good, what is the need of the combinations? And as we can see, very few patients remain on the therapy after 2 years. We need to further improve outcomes in the EGFR mutated patients. And very few patients have a very good 5-year OS rate, highlighting the heterogeneity of this disease. So the question which came was, will the addition of chemotherapy to EGFR TKIs help improve the outcomes? And this was answered by 2 trials, the NEJ009 and the TMH study, which showed that adding gefitinib to chemotherapy in treatment-naive patients does have a benefit in OS and PFS. So when we look at the patient and start him on monotherapy or a combination therapy, the key questions which arrive to our mind are the efficacy, safety, and the patient-related. Efficacy will include PFS, OS, CNS, EGFR subtypes, co-mutations like P53. The safety will include the safety profile, convenience of usage, the monitoring required, and the hospitalizations which might be needed. And the patient's preferences, ECOG, PS, and comorbidities are the main patient factors, which will personalize our treatment. So, is the single agent osimertinib optimal for all patients with EGFR mutated patients? And the answer is a big no. Because as we can see in the left side, we have some early progressors in the cohort in which only single agent osimertinib was given. And also, if we see on the long-term responders, we have very few in the 5-year outcome. So we arrived to the combinations therapy in EGFR mutations. The first one was the FLORA2 trial, in which osimertinib was combined with pemetrexed and platinum. And then we have the trial with lazertinib, with amivantamab. So again, the question is there still a role for single agent osimertinib? And if yes, then for whom? And should all patients will be considered for combinations? And again, which will be these patients? So coming to the 2 main trials, which are the FLORA2 and Mariposa, people have tried through meta-analysis to analyze which patients to be considered FLORA2 and which might be considered for Mariposa. And they have analyzed the significant things like EGFR mutations. Is the patient having brain mets or not? The patient having liver mets or not? Is there a TP53 co-mutation positive? A baseline ctDNA positive? And low clearance EGFR data. Though these decisions can be made via these meta-analysis, but cross-trial comparisons are usually not very encouraged. Also, when we look at the FLORA2 trial, in which osimertinib was combined with chemotherapy, we see in this forest plot, there is benefit across all subgroups, more so in the CNS metastatic patients, in both PFS and OS. Also, when we look at the final OS survival analysis in FLORA2 and Mariposa trial, it's very interesting because in FLORA2 trial, in the osimertinib arm, the median OS was only 37%, wherein osimertinib plus chemo arm, it was 47.5% with a hazard ratio of 0.77. Similarly, in the Mariposa trial, the osimertinib monotherapy had a overall survival of 36.7 months, while in the amivantamab plus lazertinib arm, it has not yet been achieved. And it has a hazard ratio of 0.75. Though it is only matured 57% FLORA2 and 45% in Mariposa, it is still significant. And the most important point which we do encounter in our OPDs is the presence of a TP53 co-mutation. And in this, we have seen in both the trials, it is prognostic in both Mariposa and FLORA2, but predictive only in the Mariposa trial, probably because the sample sizes in the subgroups are different. So to answer this very specific question, that in a patient with co-mutation of EGFR with TP53 subclone, which is very common, osimertinib should or should not be added with chemotherapy. And this was the top study. And as we can see in the study, there was a progression-free survival benefit with 34 in the combination arm versus 15 in the osimertinib monotherapy arm with a hazard ratio of 0.44. Also in the OS, we can see osimertinib chemotherapy arm was 48.4 months and osimertinib arm was 36.5 months with a hazard ratio again of 0.57. So the top study did suggest that TP53 co-mutation with EGFR, we should definitely use a combination. Though the OS data is still immature, but the PFS benefit is still significant. And as we can see in the safety profile for consistent as in the FLAURA2 trial. And so these findings do provide a key evidence to support a molecular risk guided individualized treatment strategy for EGFR mutated advanced NSCLCs. Having completed our treatment via FLAURA2 or MARIPOSA2, we can see that we have to monitor these post-progression areas of the patient. And hence interval scans, including brain scans, were included in both the trials, FLAURA2 and MARIPOSA. And as we can see, subsequent therapy was received in 77% in FLAURA2 trial and 76% in MARIPOSA trial, which again makes us believe that this is a very good number of patients receiving subsequent therapy. So there are not very major complications or toxicities with these therapies. Also, when we see in FLAURA2 trial, there was a 72% crossover in the patients who received chemotherapy osimertinib arm, while the MARIPOSA trial did not had any crossover. Also, when we look at the toxicity profile in all the three arms, including monotherapy chemo, or amivantamab lazertinib, we see definitely the toxicities are a bit more with osimertinib chemotherapy arm, more so in the patients having cytopenias and diarrhea, while in amivantamab lazertinib, the subcutaneous toxicities and rashes remain significant, including the infusion reactions. So we are in the era of optimizing the supportive care while we are intensifying the doses of these regimens, including the prophylaxis regimens like Cocoon and VTE prophylaxis. Also, after giving these therapies, we have to look into the heterogeneous mechanisms of acquired resistance in the osimertinib patients, which mostly are on target or off target. The on target ones include the EGFR mutation, the receptor mutation, or a bypass like MET or HER2, or a histological transformation, which is rarely seen with a squamous cell transformation or a small cell transformation. And 48%, the half of them still remain unknown. So what lies ahead? So as we know that there is MET-driven resistance after osimertinib represents a major clinical unmet need. And since no target treatment options are available for the patients currently who develop resistance to osimertinib, rational drug combinations would be needed in the future. Also, we have savolitinib, which is a selective MET inhibitor to overcome MET-driven resistance, though not available currently, but it is still in the pipeline. And ADCs have come into lung cancer also. And the advantages of them being the bystander effect, the immune modulator effect, and the targeted role. We now have ADCs against TROP2, which is dapirolizumab deruxtecan, sacituzumab, and sacituzumab. Also, HER3 ADCs are now being evaluated like patritumab deruxtecan. And after these targeted treatments are exhausted in these patients, there is no standard of care in further lines. So substantial mix of treatment options is found. And it is done on the basis the patient is exposed to prior treatment or not. And when we look specifically to our patients, the Asian patients which have a higher incidence of EGFR mutations, there is a consensus guideline which says that combination regimens like FLAURA2 and MARIPOSA should be considered for all advanced EGFR mutation patients as better treatment options. And also, the participants highlighted that safety and tolerability is the most significant differentiating factors between OSI plus chemo regimen and the amivantamab plus lazertinib regimen. And when we look at the NCCN guidelines, though osimertinib monotherapy is still a category 1 recommendation, but we have to know that combination therapies have also moved up to category 1 now. So to summarize, combination therapies do provide a better progression-free survival and overall survival, with FLAURA2 trial PFS being 25.5 months and MARIPOSA trial being 23.7 months. Also, OS is superior with a hazard ratio of 0.77 in the combination therapy. And these OS results from FLAURA2 suggest osimertinib plus chemo is the way forward. Also now, We have osimertinib as the cornerstone of the treatment, definitely yes. We have to understand the resistance mechanism, especially the MET amplification. The combination therapies have to be promoted up on the first line settings. And after resistance, we should keep a look on the emerging therapies, especially the ADCs. Thank you.
So thank you, Rishabh, for this talk. So do you prefer the combination of both osimertinib along with this chemo in all EGFR mutated or selective subset?
Sir, I will, firstly, the most important factor would be the performance status of the patient.
Yeah.
If it is good, I will definitely try to go for a combination therapy.
Even-
If it's 2, 3, I will be more towards monotherapy first.
Yeah. So
And-
even if L858 or exon 19, so in both situations you can add chemo plus this or
Yes, we can add chemo plus this. The most important thing remains is the TP53 mutation patients, where we should definitely go for a combination therapy.
okay. Thank you. Thank you, Dr. Rishabh, for this talk. So for the next talk, I invite Dr. Anish Shrikant. I think the session is delayed by the 10 minutes. So I invite Dr. Anish Shrikant for the talk on innovation to impact in Indian immuno-oncology ecosystem of gastric cancer. So I think the session is sponsored by the Zydus. So based on this, the talk by the Dr. Anish Shrikant from Delhi.
Hi, am I audible?
Yeah.
Yes, sir.
Louder.
Sir, should I
Can you
share this?
Can you share my slides?
Okay, sir. Okay.
Please complete within 10 minutes. Huh?
Yeah, sure, sure.
Yeah.
Sir, is it visible?
Yeah, it is visible. Yeah. Okay. So now the topic of interest is innovation to impact role of nivolumab in GI cancers. Next slide. So we will be talking about biosimilar, that is Trista. That is the novel biosimilar or the only biosimilar now we have in a cheaper rates. That is of nivolumab 40 mg and 100 mg. So Trista is now widely used among all the physicians at various places in our country, and it has improved definitely accessibility and affordability of majority of patients. Next slide. So it is next slide. It is also same glycosylated human monoclonal antibody with a 143 kilodaltons, and it is also genetically engineered, and it is developed as the same pharmaceutical composition as the innovator of nivolumab by BMS. Next slide. So approved strengths are of 40 milligram in 4 ml or 100 milligram in 10 ml. And we all know it is given by IV formulation. Next slide. So nivolumab approved indications in gastroesophageal junction or gastric or esophageal carcinoma. Nivolumab is used as in combination with fluoropyrimidines or platinum containing doublets, or also post neoadjuvant CTRT for adjuvant treatment in completely resected but residual pathological disease patients. Next slide. So coming to Checkmate 649, which is a previously untreated, unresectable, advanced or metastatic gastric or gastroesophageal junction, which are not known to be having HER2 positive disease with good PS, was randomized to nivolumab 360, which is of 3 weeks with Xelox, or 2 weeks with 240 mg with FOLFOX or Xelox FOLFOX, or with a nivolumab ipilimumab combination followed by nivolumab maintenance. Primary endpoint is of OS and PFS, and PDL1 CPS greater than or equal to 5 is stratified again. Next slide. So coming to PFS, duration of response, and CPS curves, all the 3 curves are favoring nivolumab based combinations. Next slide. Both in intent to treat population also. Next slide. So this slide again summarizes Nivo plus chemotherapy provides a median OS of 13.7 months versus 11 odd months in chemotherapy alone arm, and median PFS is also more than 1.5 months with a hazard of 0.79. In PDL1 stratified again CPS greater than 5 scoring, the advantage is more, that is a 14.4 median OS months versus 11 months, and median PFS is 8.3 versus 6.1 months. Again, the hazard is around 0.7. Next slide.
Sir, there is a request from Zydus. Please switch on your camera.
Yeah, sure. Actually, I have switched on my camera, but it is your screen because as you are sharing, you might be visible. I've already switched on my camera. So again, at OS data at 5-year follow-up, Nivo plus chemotherapy is better than chemotherapy. OS for overall population is 12 months versus 6 months, and PDL1 greater than CPS greater than 5. It is 16 months versus 6 months. Next slide. So conclusion, as we all discussed, that nivolumab has provided superior OS and PFS along with chemotherapy combination, and more so in PDL1 greater than 5 population. Next slide. So again, there is another study called Checkmate 577, which is used as an adjuvant treatment of esophageal cancer or gastroesophageal junction cancers. So patient with stage 2 or 3 esophageal carcinoma, gastroesophageal junction disease, post neoadjuvant chemoradiotherapy, after plus surgical resection, after post surgical resection, if anyone is having residual disease, primary endpoint was DFS, and nivolumab was used as 240 milligram 2 weekly for 16 weeks, then 480 milligram 4 weekly when compared with placebo, and it is given up to the time duration of 1 year. Next slide. So when we come to the outcome, the median DFS was 22.4 months in nivolumab population versus 11 months, and it is 35 versus 51.7 months median OS. So again, an impressive p-value of 0.0003 for a median DFS and 0.10 for median OS, with a Nivo 31% reduction in risk of recurrence or double median DFS was found. DFS and distant metastatic free survival benefits were definitely there with adjuvant Nivo and were maintained even at 5-year follow-up when compared with placebo. So 5-year OS rates were definitely higher with nivolumab, that is 46% versus 41%. Next slide. So here again, the durability was maintained by seeing this median OS curves, that is 51 versus 35 months. Next slide. So again, among the patients with esophageal gastroesophageal junction tumors post neoadjuvant chemoradiotherapy, if no pathological response, pathological residual disease was present, then Nivo would be a good choice. Next slide. Coming to gastroesophageal junction and esophageal cancer. So only IO spanning the full disease continuum was nivolumab, whether it is in first-line advanced or metastatic setting or post-neoadjuvant CRT setting. Then, and it is having a strong evidence as IO chemotherapy backbone as in Checkmate 649 when it is combined with platinum and fluoropyrimidine standard, and less biomarker dependency. Most of the times, it is not stratified as with high HER2 positivity as in Keynote 811 or high PDL1 enrichment as in Rationale 305 study. So it enables us to early initiate IO without much stratifying the enriched populations. Next slide. So the only IO with clear adjuvant standard is again nivolumab, that is Checkmate 577, where DFS is double, and no competing IO has matched these results in at least post-adjuvant settings. Next slide. So nivolumab in esophageal squamous cell carcinoma indications, again, the same. We are again reiterating that nivolumab in combination with fluoropyrimidine and platinum containing chemotherapy. Nivolumab is also used in combination with ipilimumab as first-line treatment in adult patients with unresectable or advanced or metastatic ESCC for tumors expressing PDL1 greater than 1%. Next slide. So this is Checkmate 648, where patients with unresectable, advanced or resectable or recurrent metastatic esophageal cancers were again stratified into nivolumab plus chemotherapy versus nivo-ipi combination versus chemotherapy alone. They were given accordingly as till progression between beyond PD was permitted for some nivolumab arms. Next slide. So co-primary endpoints was OS and PFS, and blinded independent central review in patients with tumor cell PDL1 greater than or equal to 1%. Next slide. So when coming to the curves of overall population, OS at 2 year was 29% versus 19%, and median OS is 12.8 versus 10.7 months in Nivo plus chemo versus chemo arm. Next slide. In PD-L1 greater than 1 population also, 2-year OS rate was 31 versus 12% with Nivo plus chemo arm versus chemo arms. Median OS is again 15 versus 9.1 months. Next slide. So OS and PFS at 5 years, when coming to median OS duration was with the Nivo plus chemo in PD-L1 greater than 1% is 15 months versus Nivo plus EP it is 13.1 months versus 9.1 months in chemotherapy. So what this proves is again Nivo either in combination with chemotherapy or with ipilimumab avoiding chemotherapy is better than chemo alone arms depending on performance status of the patient and given scenarios. Next slide. So Nivo plus chemo or Nivo plus EP demonstrated definitely a long-term survival durable benefit and more durable responses versus chemo after 5 years of follow-up in these subset of patients. Next slide. We all know that demonstrating a survival benefit in esophageal carcinoma, particularly when it is unresectable or metastatic, is tough when compared with historical data. Even providing such a benefits with either Nivo or in combination with ipilimumab is always desirable than having a chemotherapy alone arms if always affordable and accessible. Next slide. So coming to attraction 3, it is again unresectable advanced recurrent, that is of second line esophageal carcinoma, where nivolumab 240 milligram IV alone was used versus investigator choice of chemotherapy, that is paclitaxel or docetaxel was used, either a 1 weekly duration or a 3 weeks duration, continued until disease progression. Again, minded the primary endpoint is OS and 419 patients were enrolled. And again, we can see that nivolumab singly used in second line settings when compared with chemotherapy alone physician of choice arms. Next slide. Next. So median OS of 10.9 versus 8.4 months with an impressive p-value of 0.019 in nivolumab versus chemotherapy arm. At 36 months follow-up, 15% patients were alive on nivo alone arm versus 8% in chemo arm, almost doubling of the percentage of patients alive at this setting. Minded, this is recurrent setting where second line treatments in esophagus are not always encouraging. However, chemo less regimens such as only nivolumab has also provided a decent survival benefits in the population who are immune enriched or having a durable clinical benefit. Next slide. So nivolumab as second line, as we already discussed, has definitely provided a best benefit and also well tolerated over the 3-year follow-up period. Next slide. So I would like to reiterate again that only IO across breadth and across the lines of the therapy is nivolumab, and it is PD-1 inhibitor. We all know that with robust evidence, definitely in first line as checkmate 648 and second line as attraction 3. So this demonstrates nivolumab superiority in esophageal carcinoma. And also it has provided survival benefit irrespective of the PD-L1 status in majority of the settings. Attraction 3 is also where second line benefit has also been found in PD-L1 low or negative tumors. Most IOs show greater dependence on PD-L1 as per available cutoffs as per the notified platforms. So flexible first line backbone, whether it is dual IO or IO plus chemo or chemo-free regimens also can be planned, such as Nivo plus chemo as a broader applicability and a chemo-free option such as nivolumab plus ipilimumab as per affordability. Second line benchmark is not yet matched by any other IO, such as attraction 3 remains global reference for second line IO in esophageal carcinoma. Next slide. So again, I want to reiterate, this is the first biosimilar breakthrough in immuno-oncology, and we all know the data says now Trista is widely used oncology drug across length and breadth of the country, and even we can hear from our colleagues or even known to people that or from our patients or health caregivers that it is working well in majority of the population, and it is also providing durable immune responses in majority of the tumors such as head, neck, or renal cell carcinoma or esophageal cell carcinoma as we discussed. So definitely we thank Zydus for bringing such a novel molecule, for accessibility and affordability So we are always having exciting times ahead. Thank you.
Dr. Shrikant, for this talk, and thank you for Zydus for sponsoring this session. So I invite for this next session Dr. Bharat Vaswani sir, who is the clinical director, medical oncology and hematologic wing at Yashoda Hospital, Hyderabad, for this talk about this from the lens of ASCO and ESGO 2026 gynecological updates. So over to you, sir.
Good evening, Devesh. Are my slides visible first?
Yes, sir. Yes, sir. Visible.
Am I audible?
Yeah, audible, sir.
So thank you, dear, for a kind invitation. I will always thank Tarun, who always allows me to present something which is unbiased, and it gives me a chance to go through the entire conference slides. So today, in the next 15 minutes, I'll be presenting about endometrium and ovary. Because it is 15, I could not cover everything. What was new in this ESCO 2026? And there was a ESMO Gynecological Conference, which was from 17 to 19 June 2026. So let me start with ovary. So what was focused in this ESCO was a platinum-resistant ovarian cancer subset. So I'll be discussing about you. So when you talk about classical carcinoma ovary, neoadjuvant surgery, adjuvant, then if it is HRD or a germline, we give OLA plus BEV. Then subsequently majority of 3C relapse, and you keep on giving treatment till the patient gets exhausted, side effect, intolerable toxicity, or probably a death, which is a point. And when you talk about options in platinum resistant, if there are PGs or this is a very good slide to summarize what is there in ovarian cancer, which we have option in platinum resistant. So the studies in this ESCO and concentrated on the platinum resistant ovarian cancer. So when you talk about platinum resistance till 22, whatever studies came, none of the studies had which had an overall advantage. Remember your Aurelia, BEV maintenance, or Trinova, Tremetinib, which was angiotensin. Both these studies showed that there was a PFS benefit without the OS benefit. But in the last 3 years, we have 4 pivotal studies which shows that yes, there are 4 new drugs now which are shown OS. 3 has shown OS advantage, and 1 new drug that I'll discuss from Chinese, they have shown a PFS advantage. And that 4th drug was Chia Aurora kinase inhibitor, which was a good drug, that we tell you that. And this was one of 2 things which was most talked about in ESCO 2026. One of this was the CIPRO study. So again, a slide which, if there are any residents, they should remember that before ESCO, these were the 3 trials which we had the overall: Mirasol, Mirvetuximab, Keynote B96, Pembro, and a Destiny, which was for 3 positive. All the 3 studies showed that there was a statistically significant improvement in PFS, but more importantly, for the first time, we have 3 trials which showed that was a statistically significant improvement in overall survival. So this was the first study, which was a Rosella. We remember we have already seen a Rosella, but this was a subgroup analysis of Rosella. What is Rosella? So Rilacorilant, which is a glucocorticoid receptor antagonist, with nab-pacli versus a single nab-pacli in platinum-resistant subset. These was a subset analysis for those who had already taken taxane. All of us know that Rilacorilant is a novel selective GR antagonist, and it sensitizes the cancer to chemotherapy by reducing the cortisol levels in the body. So remember, less than 6 months progression on the last platinum, 1 to 3 lines of chemo. Try to concentrate in the lower part of the curve. So 50% were 3rd line and 43.1% were 4th line of chemo. So heavily treated. Around 87% had taken taxane more than 6 months prior, and the taxanes in the last chemo was 20% had taken even taxane in the last. So probably you can say they continued taxane and added Rilacorilant. The primary endpoint was PFS and OS. Now try to concentrate on the timeline that I'm trying. At 1 year, twice the number of patients were progression free. A quantum of benefit of 1 month with 30% reduction in the risk of progression. Now, what was important was the primary endpoint of OS. So a quantum of gain of 4.9 months. So from 11.9 to 16. When you remember, 35% reduction in the risk of death. better than what it was for PFS. So it was statistically significant. Now, in a subset analysis, when you see the forest plot, less than 6 months, more than 6 months, taxane in a previous, taxane not in the previous, there was an improvement. So irrespective, when you add this relay correlate, with you have given taxanes or not in the previous or before, there will be an improvement. Now, is this drug toxic? So non-toxic, you can say 10% discontinuation. Fatigue is the most common, some diarrhea, some skin changes. More importantly, no cases of adrenal insufficiency because it is glucocorticoid receptor antagonist. So what does this suggested that you don't need a biomarker to give this drug? 30% improvement in progression-free survival and 35% improvement in overall survival with the absolute gain of 4.5 1 month, irrespective of what you had used in the previous lines of therapy. So once the drugs came, I think everybody will use it. Now, this is a new drug in the treatment armamentarium, Chia-Ora-Nib, with Taxols or without. So again, the other arm is weekly paclitaxel. Please remember, my experience, whenever you use a Taxol in the resistant setting, please use weekly pacli, not a 3-weekly or a docetaxel, because you remember your Aurelia study everywhere. What has to be used in resistant is a weekly. So you can combine it with this drug. Now, what is this drug is? It is a RRO-B kinase inhibitor. And what has been suggested is then once the drug develop resistance, these are all the bypass pathways which are there. So when you combine with it, so inhibition of RRO kinase can halt the cell cycle at the G2N phase, represses mixed signaling as well as increases the stability of P53. Remember your ovary, P53, 95% mutated. So it is synergistic to chemo. Primary platinum refractory. This was one of those that I will be telling 20% were totally refractory within 1 month. So Chia-Ora-Nib plus weekly pacli versus a weekly paclitaxel, and the primary endpoint was PFS, secondary endpoint was OS also. So the schedule is 1850. Now try to concentrate. I'll go back. More than 30% were 4th or more lines of treatment. Platinum refractory was around 13%, but platinum resistance was 87%. So these were more heavily pretreated patients. Absolute gain of close to 2 months with a 58% reduction in the risk of progression. So again, we have a good Chinese drug, which is one of the good. The problem was the OS was not statistically significant. So if you see the OS, it was 12.9 versus 12.1. So probably again, we may debate whether it was really good. But what was important and which was highlighted in the highlights of the Eurobri was, if this was the last line of treatment, there was a statistically significant improvement in OS with around 40% reduction in the risk of progression. So if you have used CP and you could not use any other cancer drugs, the patient survived for 8 months. So again, this reemphasizes that you have to use all your active agents during the course of the treatment, and probably the most heaviest treated patient who was given this Chia-Ora-Nib survived for the longest period of time. So again, a new drug that is added in the ovarian armamentarium. The amazing thing was 4th and most lines of treatment, 77% has tumor reduction. And this is statistically significant. I have never think of your drugs in a ovarian cancer in the 4th or 5th line, and you can never think of any drug which has 76.8% tumor reduction. So yes, it is a statistically a drug which is potent enough at all. Are there discontinuation? So only 6.1% with this Chia-Ora-Nib. So what we can understand is this is supposed to be a slightly safer drug. One can understand with such a heavily treated and only 6% discontinuation. Apart from fatigue, some hematological, 2 significant side effects are proteinuria and hypertension. Again, those sorts of drug, which is a group-related side effect. So a drug safer. So PFS improvement, safety profile is manageable, and it improves survival in those patients where you could not give subsequent line of therapy. So this is what I told, and now this field has started getting crowded. You have 5 trials now in a platinum refractory. 2 drugs I have mentioned, both improved progression-free survival. Definitely relacorilant improved the OS. This drug did not improve the OS, but improved those in OS in those who were heavily treated and could not take any subsequent chemotherapy. The third thing was should I give 3 cycles of chemo and operate, or should I give 6 cycles of chemo and operate in a neoadjuvant? So it was a chrono randomized study. So arm A had interval cytoreduction and 5 cycle. We give 3 plus 3, but they have given total 8. And the other arm was they completed 6 cycles of neoadjuvant, had a DCS, mean delayed cytoreduction, and another 2 cycle. No need to go through it because this trial suggested that giving more chemo in neoadjuvant doesn't add up to anything like disease-free survival, tried to first treatment, OS, post-operative mortality, severe mortality. So giving more in a neoadjuvant doesn't help much. The advantage is in the first 3 cycle, I always believe you operate, and probably the next 3 is a maintenance therapy. This was the most talked about trial. Please remember, this is something that we can discuss later on. Does dietary alteration during chemo improve outcome? So patient asked us, sir, खाना खा के आना है कि नहीं? खाना बाद में क्या खाऊं? So this was the most talked about study, which I have only put one slide. Timing of eating with neoadjuvant chemotherapy. So newly diagnosed ovarian cancer patient, 2 arms. One arm had short-term fasting and other arm took the formal food. Remember, this was it. So 36 hours before to 24 hours at the end of each cycle, water, herbal tea, no caffeine, alcohol, nicotine, 200 ml of vegetable juice and small quantity of light vegetable, no non-veg. What they observed was that the insulin level for those who had fasted was lesser. Remember, insulin is a chemo inhibitor, or it creates resistance. What did they measure? They measured those with a complete CRS. So see, for those who had a short-term fasting, 58.8% had complete response to chemo versus 17.6%. A hypothesis generating trial, but the most exciting data here, and probably if you go through internet, which is the most important 3 studies in this ESCO, this will come first. So I wanted to see. So in future will probably be more so. Probably I have started telling my patient to get with a light breakfast. Probably you can't tell because this is a small study, but something which will change our practice if replicated in the larger trial. Second is endometrium. So what did endometrium? I told platinum resistant was the theme for ovary. And what was the theme for endometrium? Long-term data in the first line treatment. So the long-term data of RUBY and the pembrolizumab study. So see, ESCO, there was long-term survival and cure model. Now you put your question, if you have time, in Google, which is the most important data in this year, endometrial cancer, I'll tell you. Remember, this was at 54%. I'll tell you why. Because this will come everywhere. So a 4-year data of RUBY trial. The same came again in ESMO gynecological. Sustained remission and long-term survival of RUBY study. So what did it suggested? At the end of 4 years, 72 versus 40 with a 66% reduction in the risk of death. This is an amazing data, but I was more excited about this data. At 4 years, only from 1 to 4 years, only 4 new progression happened. So if you do well on first year, 65.3, at the end of 4 year, only 4 patients it progressed. So probably if you remember your data, can you remember is data, crown data for lorlatinib? And this data, this looks more or less the same, that at 4 years, there 57% was still progression free with 70% reduction in the risk of progression. So they tried to have a cure model. This is something for the first time they went. At 4 years, disease-related mortality with dostarlimab was 0. So no patient died from this year in the last 1 year. And that is why they calculated the cure. So how do we calculate cure? At the end of 5 years, they say that 54% will be still progression-free, and that is contaminated with core. So 54 was what everywhere I searched so many times. Every time, so if you tell your patient that if you are deficient MMR, you give this drug, 54% will be progression free at the end of 4 years, and that is at the end of 5 years, I beg your pardon, and it was 3.9% better than with or without dostarlimab. So this was the most talked about time. Toxicity with dostarlimab is not much. Some hypothyroidism, arthritis, macular. I don't think so. Whoever has used it is not a toxic drug at all. So what I can conclude is if you give your drug in the deficient MMR, you have a 3.9-fold, 3 times chance that you will be cured of this disease at the so 5 years survival. The second was a Pembro update at the end of 4-year NRG overnight study. So Pembro with carbotaxol followed by Pembro, and it was updated overall analysis in DMMR and PMMR. And for those patients who took in the deficient post or proficient ICI post progression, in those who had not been given in the first line, did the outcome differ? So if I tell you, see this. So at the end of 4 years, 78.6% patients were still surviving. Again, this hazard ratio is 0.56, which looks less impressive than dostarlimab. But please remember, there were more of 3-4 or more of a patient high risk in Pembro arm. But what is more important is see the last time. Among patients receiving post-study therapy in those in placebo arm, 93.2% of patients in the control arm received the ICI. So giving first line ICI versus second line, you can always say still there was a substantial gain, because around 20 to 30% will never go for the second line in any of the cancer trial. Now, when you talk about proficient MMR, this is something that we still have not accepted it as a first line, but there was a numerical gain of 7.2 months. Again, it was not statistically significant, but I think we can debate whether you should give it in the first line in a proficient MMR. But yes, this is debatable, and I may not be a person who will tell to give it in everyone. So what did this trial suggested? A very good in the MMR 0.56 and proficient also a numerically better. But what is more important is it's tried to tell you that when you give it in the Pembro in the second line, probably most of your patient or a subset may not receive it. So DMMR deficient, probably the best thing is give early, because if you remember that 54% have, except for I remember Crown, I don't remember a study where it was PFS at the end of 5 years is so good. So should I give dostarlimab or should I give Pembro? If you see the 4-year data, 78.6 versus 72.8. So nothing to choose between it, although the hazard ratio of dostarlimab is better. But how do I choose? So probably in a non-serous, dostarlimab had carcinosarcoma other subset also. So maybe in the other subset, you should use dostarlimab, because we don't have any data of Pembro. Otherwise, how comfortable you are with the drug, you have to choose. The last data, because it is an Indian AIMS data, and I think we have started using it. If I ask you what are the 4 subsets of endometrial cancer, so a P53 mutant, a POL mutant, a MSI high, and the last is no specific molecular profile. So whenever you see a patient of no specific molecular profile, the first thing you do is do a ERPR, HER2. If you want to give chemo, give chemo. If you feel this is slow growing, the option to your door is start on a letrozole plus a CDK4/6 inhibitor. As I'll be telling you now, there are 3 studies and the responses are quite good. So -275, 100 and 125. Now, when you look about it, is 32% objective response rate with around 50% clinical benefit rate at 6 months. Remember, these are all probably a patient who have already received medicine. Median PFS of 7 months, OS has not been reached. So when you look into review of the literature, now we have 3 studies, Paleo, ABIMA study and Fulvestrant with ABIMA study. Of course, numbers are less, but what is consistent is see the PFS in 3. 8 to 9 month PFS. If you see the ORR, again, 30 to 50% of ORR. So I have used in quite a few patients. So I do ERPR specifically. Can I prognosticate my endometrium in NSMP? So I do ERPR. If it is positive, it carries a good prognosis, and I use my CDK4/6 in the second line. Because of the shortage of time, I have not put it more. There was sort of exciting data. So I told you 7 data. Remember your fasting data and this oral data. And I end my talk with my favorite slide, which I always fit with the quote of Socrates. The secret of change is to focus all your energies, not on fighting the old, but on building the new. I again thank Devesh for the kind invite. I thank Tarun again for allowing me to present what I like more, so reviewing the entire data. Thank you. God bless you, man.
So thank you, sir, for this wonderful talk. So I think I am convinced with this endometrial data. So I think dostarlimab and pembrolizumab we are using clinically. But in ovarian cancers, I think the drug right now is not available in India. I think we can use in future along with in platinum-resistant CA ovary.
It is always exciting to be a medical oncologist now,
Yeah.
because you are getting so many good drugs. Ovary, you already had so many drugs. Now there are 3 new drugs also.
Yeah.
Probably, and patients are always fitter. So you will have lot of options again.
Yeah.
You have 3 new, 4 now. Immuno came, then mirvetuximab is since for a long time, probably is launched. Then you came the other drug, the third, and now there is Chia or relacorilant, and then now there is Chia or so there are so many drugs coming up. And then the last 3 years, there are 4 positive studies now. So probably for if there are students, they could always a good question and lot of data available for this platinum resistant.
So thank you, sir, for enlightening us.
I think, Devesh sir, I'm sorry to interrupt, but I think, heads off to Dr. Bharat Vaswani sir, the way sir has presented is mesmerizing. I'll say the word mesmerizing. Absolutely. So, sir, thank you so much
Thank you.
for your time and energy and your presentation. Thank you so much, sir.
Thank
Truly
you, sir.
obliged.
Thank you.
Devesh
Thank
sir,
you,
over
sir.
to you, sir. Over
Yeah,
to you.
sir, moving ahead on second part, the session of breast cancer. So I invite Dr. Rohit Swami for this talk on this, the dapirolizumab deruxtecan as a first-line therapy for patients with locally recurrent, inoperable, or metastatic TNBC who are ineligible for immunotherapy. So over to you, Dr. Rohit.
Good evening, Devesh boss, and good evening, everyone. Manya, can you please share my slide?
So we can complete within 10 minutes, Rohit.
Sure, sir, sure. So, as Devesh boss has said, I am going to discuss about this Tropion Breast 2 study, which compared Dato-DXd versus chemotherapy of choice as per the investigator in metastatic TNBC, whether it was de novo metastatic or recurrent metastatic TNBC. Next slide, please. So key takeaway, what we will see in the next further slides is that this study has shown significant PFS benefit with Dato-DXd as well as significant overall survival as compared to chemotherapy with Dato-DXd. And the secondary endpoints, which were time to first subsequent therapy or time to second subsequent therapy as well as PFS2 was also much better, significantly better than chemotherapy alone. Next slide, please. So study design is the patients who were randomized were basically metastatic TNBC who had either previously received chemotherapy or immunotherapy in the curative setting, but had never received any chemotherapy or systemic therapy in the recurrent setting or metastatic setting, upfront metastatic. Immunotherapy is not option at present, as well as good PFS. And the main thing of this study was that DFI was not a bar to enroll the patient. Even the patient who had very small DFI of less than 6 months after curative treatment, which were around 15% of population, were also included in this study. Rest other all clinical trials of ADC has excluded this population because this population do very bad. And these patients were randomized into 1:1 patient into Dato-DXd arm or investigation choice arm. Endpoints were dual primary endpoints were PFS by blind independent review or overall survival. And secondary endpoints included PFS by investigation choice, overall response rate, duration of response, disease control rate, and as mentioned, time to first second line therapy, PFS2, and time to second line therapy. Patients were further substratified according to geographic region, PDL1 status more than 10 or less than 10, and DFI history. Next slide, please. So baseline demographics were well matched in both the arms. Around median age was 62, and all the patients were of PS0 or 1, and 40% of patients were Caucasian. Similarly, 50% of patients were Asian. So good representation of Asian subset also. De novo metastatic were 35%, and DFI 0 to 6 was around 15%. And rest of the patient had DFI of more than 12, around 50%, and less than 12 months, around 21%. Similarly, PDL1 less than 10 were around 90, and more than 10 were around 11. So these were basically all were immunotherapy ineligible patient, or as the TNBC dictates, 80% of patient has the visceral metastasis with liver and brain mets, and more than 3 metastatic sites are seen in 40% of patients. And NAP, Pacli, eribulin, carboplatin, capecitabine were chemotherapy of choice of investigator. Next slide, please. So this study showed that as compared to chemotherapy alone, there was significant statistically significant PFS benefit with Dato-DXd of around 5 months, mean a PFS benefit of around 5 months as compared to chemotherapy alone. by blind independent review, as well as survival benefit of 5 months as compared to chemotherapy alone. So median overall survival was 23.7 months as compared to 18.7 months with chemotherapy alone. And safety profile was manageable, well tolerated, and treatment discontinuation was less as compared to chemotherapy arm as compared to Dato-DXd. Next slide, please. So secondary efficacy endpoints were further studied, and these TFST, PFS2, and time to subsequent second-line therapy were also analyzed to see that whether this ADC has a long-term effect on the overall survival of the patients. Next slide, please. And time to first subsequent therapy was statistically significant longer as compared to chemotherapy with Dato-DXd. So median TFST was 10.9 months as compared to 5.6 months. So it numerically favored Dato-DXd. Next slide, please. And similarly, time to second line progression was also significantly much better with Dato-DXd 15.6 months as compared to 11.8 months. And this shows and is consistent with the overall survival result of this study. Next slide, please. And time to second subsequent therapy was also 16.7 months with Dato-DXd as compared to 12.6 months. So it also numerically favored Dato-DXd. Next slide, please. So next therapy, second line therapy, which were received by the patients in both the arms. So majority of patients received sacituzumab govitecan followed by T-DXd in both the arms, and time to first subsequent line therapy was longer. Time to second subsequent line therapy was also much longer with Dato-DXd as compared to chemotherapy. Next slide, please. So coming to summary of this study, there was significant PFS benefit by blind independent review, by investigator review. Time to first line subsequent therapy was longer with Dato-DXd, PFS2 was longer, and time to second subsequent therapy was longer, and then there was significant overall survival benefit with median overall survival benefit of around 5 months with good hazard ratios. Next slide, please. So concluding my presentation, this TROPION-Breast2 study has showed that first line Dato-DXd as compared to chemotherapy gives us PFS benefit, survival benefit, as well as also gives us PFS2 benefit. So this Dato-DXd can be the new standard of care in the first line therapy as compared to chemotherapy in immunotherapy ineligible patients.
So,
Thank you everyone.
So thank you, Dr. Rohit. I think in the triple negative breast cancer subtypes, I think the very fewer options in metastatic breast subtypes.
Definitely.
Especially where the immunotherapy options is also not available. So I think this is the newer options, and I think can eligible for the patient.
Immunotherapy will be better with Dato-DXd as well as sacituzumab also.
Yeah.
These are two options.
So thank you, Rohit, for this.
My pleasure, sir. My pleasure.
So for next talk, I invite Dr. Jitendra Pehlajani for the talk on this preserve era BC. I think Giredestrant plus palbociclib. I think the very name is very tough. I think Jitendra's job is also very tough.
No, it's not
Over to
that
you.
much tough. Yeah, thank you so much for the invite, Devaj boss. So we'll see how the hormone positive landscape is changing day by day. Next slide. So this is a ASCO 2026 extract, which says that Giredestrant plus palbociclib versus letrozole plus palbo as first line therapy in patients with ER positive, HER2 negative breast cancer, whether they were advanced or metastatic. Primary analysis of a phase 3 study, PERSEVERE era BC trial. So next slide. So here we can see the three key take points. That first line, Giredestrant plus palbociclib resulted in a numerical improvement versus letrozole in hormone positive, but there was no statistically significance still yet achieved. And it was well tolerated with a manageable safety profile, and there was no unexpected finding. Further exploration is needed to assess which patient may benefit from Giredestrant in the first line. Next slide. So this is the background, the combination of ET with CDK4 inhibitor in the current SOC for first line treatment. Giredestrant is a potent next generation oral SERD and full ER antagonist designed to drive deep and sustained inhibition of ER signaling. In a phase 3 clinical trial, Giredestrant has demonstrated superior efficacy compared with endocrine therapy like AIs as adjuvant monotherapy like ADARA-BC study in combination with everolimus post CDK4 like AVERA-BC study. So here they try to use this agent in the first line metastatic HER2 positive case. Next slide. This was a trial design. There was a phase 3 randomized double-blind placebo-controlled study. So there was first-line hormone positive metastatic breast cancer, locally confirmed histological cytological diagnosis, no prior treatment for advanced disease, no prior treatment with SERD, disease recurrence if a patient on a metastatic setting of more than 12 months from primarily a secondary hormone resistant case, or if a disease recurrence is less than 12 months for patient receiving neoadjuvant tamoxifen. So tamoxifen exposure, if it is less than 12 months, were taken. So these patients were randomized to giredestrant 30 mg OD plus placebo of letrozole followed by palbociclib. So the control arm was letrozole 2.5 mg standard dose plus placebo of giredestrant plus palbociclib. So treatment until progressive disease or unacceptable toxic survival was followed. So primary endpoint was PFS as per REGIS. Next slide. So this is the statistical design. Two-sided log rank test was marked with HR estimated using a stratified Cox professional hazard model. Primary events are planned to occur after approximately 620 events, designed to detect an HR of 0.77, which is 23% risk reduction. The statistical significant boundary for efficacy was defined as an HR of 0.85. Next slide. So this is the randomization. Around 900 odd patients were randomized, and around 450 odd patients in each arm were treated. Next slide. So here we can see that almost 60 median age was 60%. American patients were similar. Asian patients was 28%. Whites were the most common population. Asia Pacific patients were also there around 28%. Majority patients were post-menopausal around 80%. Pre-menopausal patient was there. Majority patient was high ER positive. Usually 88% patients are high ER positive. ER positive was in 83%. Treatment-free interval was more than 12 months for 70% of patients. Majority patient did have bone-only involvement, and 60% patient did have visceral involvement. AI only was given around in 40% of the patient. Tamoxifen was given in the 22% of the patient. AI and tamoxifen both were given in the 20% of the patient. Next slide. So this is the Kaplan-Meier survival of PFS, and we can see that almost both the graphs are moving together. And the median, although there was a numerical 5 months data, but the confidence interval was crossing the 1. So that's why it was not statistically significant. Next slide. So this is the forest plot, and we can see that it was more or less slightly favoring towards the SERD, but it was not statistically significant. Next slide. So the secondary endpoint of OS was almost similar. The graph is parallel when we compare giredestrant with the letrozole. Next slide. So other key secondary point of ORR was similar, and the complete response was also similar. Next slide. The safety profile, both drugs were safe to use, and the primary side effect was related to endocrine therapy as well as palbociclib. Otherwise, there was similar discontinuation rate was seen. Next slide. So this is regarding the common side effects. So we can see that the graphs are more or less similar, and grade 2-3 side effects are very, very rare in both the arms. Next slide. So coming to the summary, like giredestrant plus palbociclib demonstrated a numerical improvement in investigator PFS compared with letrozole, but the hazard ratio was 0.89, which was not marked to be 0.85, with non-significant p-value. Overall and CBR was similar with both the arms. OA was immature, although no difference was observed till the data recovered, and it was well tolerated with a manageable safety profile. Another trial which is evaluating the same, and we have to wait for the data. Next slide. So we can use this agent, what I could understand, because we know that SERD are useful when patient has ESR mutant. So probably those are the patients which may be benefited, but we have to wait for the data. And due to the logistics and cost of the drug, probably letrozole is still here to stay in this time. Over to Devesh.
Yeah. So thank you, Dr. Jitendra. So I think can we use in this the endocrine refractory types? So initially progressed on letrozole. So can switch on this Gilead. I think I am understanding this molecule is little bit similar to the fulvestrant, I think, now.
Yes, yes, boss. It is slightly more potent, and it has an advantage. It is an oral molecule. So upfront line we can use when the patient having a ESR mutant. So probably in that case, it will be useful.
So I think if suppose the patient is going on this palbociclib with fulvestrant and progressed and ESR mutation was developed, so can we use this molecule along with this?
Probably that is the best way. If there is no PIK3CA mutation, so probably I would like to shift to this and ribociclib.
Yeah. Okay. So thank you, Dr. Jitendra, for this talk. I think thank you, my friends. And next, my friends, Dr. Ankur Punia for this next session. He is the senior, he is the associate professor at Mahatma Gandhi Hospital, Jaipur. I think I am seeing Dr. Ankur on virtual as well as physical mode in the last 5 to 6 months. I have not meet Dr. Ankur. So I think over to you, Dr. Ankit, for this talk.
So thank you, Dr. Devesh. So let's get into talk. My topic for today is the use of first-line camizestrant for emergent ESR1 mutation in advanced breast cancer patients. So this is the PFS2 data, which was of SERENA-6 trial, which was presented. This next slide. So we have the initial data was there that it showed a PFS benefit. Improvement in PFS increased to 7.6 months. So PFS2 was a secondary endpoint, which again showed a improvement in the PFS2 data. Next slide. So we know that breast cancer eventually everybody progresses. So we need more and more drugs. So this is one of the newer oral drugs. One was discussed in the last talk. This is a new oral SERD, camizestrant, and SERENA-6 trial was done. When it was used, it was changed based on ESR1 testing. Patients who had this ESR1 mutation, they were changed to camizestrant, and on the control arm, they continued on letrozole, and it showed a interim analysis showed a PFS benefit. It was 16 versus 9.2 months. So this is the updated PFS2 data which was presented in this ASCO. Next slide. So this is the study design. Basically, advanced ER/PR positive breast cancer patients who had received AI and a CDK4/6 for at least 6 months. They had a ctDNA testing of an ESR1 mutation. So they were basically randomized. Whenever the ESR1 was detected, they were randomized whether to continue the same AI or CDK4/6 without any radiological progression, whether to continue the same treatment or switch to camizestrant and continuing the CDK4/6. So PFS2 was basically after the first event, whenever the second event happened, that was considered the PFS2. Next slide. So this is the updated PFS data which was presented, which was already known. It was 16.8 versus 9.2 months. And at 2.5 years, almost 30% patients were on the experimental therapy versus just 2% patients who were on the letrozole plus CDK4/6 at 2.5 years. Next slide. And if you look at by different co-mutations, whether patient had a PIK3 mutation or a TP53, both of those renders a poor prognosis, but still a benefit was seen. In patient with PIK3, it was 18 versus 10 months. In for patients TP53, they did poorly, but again there was a benefit. PFS was almost double, was 12 versus 5.6 months. So this drug helped irrespective of whether the patient had the poor mutations. Next slide. Another important thing was that it has been seen that patient who have multiple ESR1 mutation tends to do poorly. So they again showed the same thing, whether a patient who had a single ESR1 mutation or multiple ESR1 mutation, it didn't make a difference. The PFS was more or less same. It was 16.8 months, whether they have single versus 9 months. And for patient with multiple ESR1 mutations, it was 15 versus 7.4 months. So PFS was almost doubled when we used oral SERDs in place of AI when the patient develops ESR mutation, whether single or multiple. Next slide. So if you look at the first subsequent therapy, what was used for patients who progressed on treatment. So for patients who were on the camizestrant arm, again, SERD or Nover ET was used in around 28% patients. Around 55% patients had endocrine therapy and rest had cytotoxic therapy. And in almost 50% of patients used oral SERDs in the control arm. So many of the patients were, exposed to the oral SERD in subsequently. So they were treated adequately, what we see in the second line treatment. Next line. So this is the PFS2 data which was basically presented. So PFS2 was statistically improved. It was 25.7 versus 19.1 month. At 2.5 years, almost 41% patients were had a PFS2 event versus 29-30%. So almost a 12% difference was there. So whether as I told you, 50% patients has used second line SERD, still there was a benefit. So it reinforces that starting the treatment as soon as ESR1 mutation develops is more preferable than rather than waiting and waiting for a radiological progression. So more or less this reinforces this tailoring the treatment based on ctDNA data. Next slide. If we look at all the subgroups, PFS and PFS2, all the subgroups benefited with the in the experimental arm. Next slide. This was the quality of life index. So quality of life in all the on both the scales, it favored the experimental arm compared to the AI-CDK4/6. Next slide. So this is another endpoint was chemotherapy or ADC-free survival. Basically, patients were not exposed to chemotherapy. Again, it was improved. It was 22.6 versus 18.7 months. So chemotherapy was delayed for patients who were using the experimental arm. Next slide. Overall survival, it's still early days. It's not mature. Hazard ratio is consistently in favor of the experimental arm, but it's still early. We don't have the events are still not reached. So we need a longer follow-up to look at the overall survival data. Next slide. So ctDNA is a upcoming thing which was the basic used in this trial was to do treatment based on ctDNA. So ctDNA, shows the dynamic tumor burden profile basically. What are the new mutations happening? So in this trial, total ctDNA levels were accessed at 4 weeks and 8 weeks of the treatment, and it was seen whether clearing the ctDNA had any impact on the outcome or not. Next slide. So it was seen that almost 50% of patients had a ctDNA clearance when the camizestrant was used, compared to just 1.9% in the letrozole arm. And patients who had a ctDNA clearance tend to do well. So coming to conclude, PFS was improved in the earlier data presented. It was improvement to 7.6 months, and PFS2, which was the secondary endpoint or the key endpoint, which shows that even when you switch early is better, and PFS2 was improved by almost similarly 7 months, and patient continued to improve without any deterioration in quality of life. It extended the chemotherapy-free survival. OS still immature, and ctDNA, which is the thing used, it almost 50% patient has ctDNA clearance. So more or less, it is going to become the standard of care in how we treat breast cancer patients. Thank you.
So thank you, Ankur. So I think we can use this drug. Is this available in India right now or not?
No, still not available.
No, I think. Okay. So I think if the disease have progressed over the fulvestrant along with this ribo, palbo, so can we use again in the next line?
It can be used. It has shown benefit in later lines post fulvestrant as well. So then the more of the SERD will be available, we'll have more understanding about the ESR1 mutations. Which kind of ESR1 mutations, particular drugs respond to what ESR1 mutations. So that will be the future in breast cancer.
Okay, thank you, Dr. Ankur, for this talk. And for the next session, I invite Dr. Rishabh Jain. The session is sponsored by the Zydus. So the topic on this present and future landscape for the HER2 positive breast cancer and Indian perspective. So I think nowadays the all biosimilar drug, trastuzumab, TDM1, as well as the pertuzumab. So all biosimilar drugs are prepared by the Zydus. I think the cost cutting and now affordable range. So I think we can, even tucatinib also. So I think we can incorporate all types of treatment in the HER2 positive settings. So over to you, Dr. Rishabh, for this talk.
So, good evening, everyone. I would be presenting on the topic present and future landscape of HER2 positive breast cancer management. And as we all know, the HER2 target therapies currently are the ones which are either the TKIs like lapatinib, neratinib, tucatinib, or the MABs like trastuzumab, margetuximab, or pertuzumab, or the ADCs, the newer ones like TDM1 and TDXT. So when we look at the spectrum of HER2 positive neoadjuvant or adjuvant therapies, the patients who should be considered for these therapies are the ones which have a high tumor to volume breast ratio, having a lymph node positive disease, high risk features like high grade HER2 positive TNBCs, or younger age at diagnosis. And in the patients which are HER2 positive, the patients which have to be considered for pertuzumab in addition to trastuzumab are effectively the ones which have a tumor diameter of more than or equal to 2 cm, or the patients which are node positive. And when we look at the efficacy of neoadjuvant pertuzumab as determined by PET-CR rates, in both Neosphere and Trifina trial, we too see an increase in PET-CR rate irrespective of the hormone status. And we do have some good real-world data from India as well. As we can see the real-world PET-CR data of neoadjuvant PHESGO from various studies, there is a retrospective multi-center real-world study to determine the efficacy and safety of PHESGO, which showed a 75% PET-CR rate with PHESGO. Another study from India is the one in which again efficacy and satisfaction among HER2 positive cancer patients, which PHESGO was studied, and it again showed a PET-CR rate of around 83.3%. And when we look at the PET-CR rate of various SIGRIMA studies across spectrum in different institutes, we do have a PET-CR rate of 75 to 76%, which is comparable to the international standards. In the HER2 therapy, we have the standard TCHP regimen with some minor tweaks, which are evident in the NeoChart trial, which questions that is the carboplatin really necessary, and the Helen 006 trial, in which we use nab-paclitaxel instead of docetaxel and carboplatin doublet. In the NeoSCAR HP study, THP 6 cycles Q3 weekly was compared with TCHP Q3 weekly, and THP was indeed non-inferior to TCHP. Also, when the Helen 006 trial was taking place, in which the weekly nab-paclitaxel was studied, we can see the PET-CR rates were indeed superior, if not inferior, and there were fewer toxicities and better outcomes with nab-paclitaxel. So, coming to the adjuvant landscape, we have the phase 3 Affinity trial. As we all know, the patients which were node positive or tumor size more than 1 cm were taken, and they were randomized into either pertuzumab, trastuzumab chemotherapy versus trastu chemo. And the latest analysis of 11.3 years does show a benefit in the intention to treat population with the overall survival benefit of around 1.8%, which were more so in the node positive patients, which were 2.7% difference. And when we look at the subgroups, there is significant benefit in the patients having node positive disease and the patients who have a hormone receptor positive. So when we look at the NCCN guidelines with respect to these trials, we do see that the patients who receive PET-CR still pertuzumab trastu combination is preferred across lines. And if node positivity is there, pertuzumab is definitely a must. And again, in the patients with systemic adjuvant therapy, we do see the patients who have received upfront surgery followed by adjuvant. In the patients who have T2, T3 disease, pertuzumab has been added in 2025 update. And as well in the node positive disease, the standard of care remains pertuzumab. So when we define the high-risk patients in the HER2 positive landscape, these are the patients who have any residual disease post neoadjuvant therapy, or at baseline, they might have a node positive disease or a T3, T4 disease with any nodal status. And herein comes the famous Catherine trial, which evaluated the patients which did not go into PACR after the neoadjuvant therapy, and they were given either TDM1 or continued with trastuzumab. And as we all know, there was significant IDFS and OS benefit, as has been shown in the long-term data of 8.4 years. And we do see an absolute IDFS benefit of 13.7% at 7 years, which is unprecedented in breast cancer. Again, OS benefit is around 4.7% at 7 years, which is very significant. An interesting point to note is that TDM1 has shown promising results even in the patient with small residual tumors. As we can see, YPT0, T1A, T1B, and TIS do have benefit with TDM1. When we look at the NCCN guidelines, it has been incorporated in the patients not achieving PACR as standard of care category 1 recommendation. From localized, let's now move on to the metastatic setting. And in the first line setting, we have the famous Cleopatra trial, in which there was a OS benefit of 17 months, which is not seen so far with any other HER2 positive metastatic breast cancer trial. And coming to the newer therapies, we do have TDXD plus pertuzumab in the Destiny Breast 09 trial, but which has a PFS benefit of 40.7 versus 26.9 months. But there are some nuances which are significant, like the OS data is not yet mature. TDXD monotherapy arms results are not yet disclosed. The long duration of therapy in first line have significant toxicities, including the financial ones. And dose reductions are seen in about half the patients. And only 30% patients could take a post-TDXD therapy. And only 43% received a prior neoadjuvant therapy. And looking at the PFS by HR, we do see a median PFS of 38 months here also. Moving on, we have the newer Patina trial, which evaluated the role of palbociclib with anti-HER2 therapy and endocrine therapy in the previously treated HR positive, HER2 positive breast cancer. And in this, the CNS metastatic patients were also included. The median PFS was definitely better, which was achieved in Destiny Breast 09 trial, though cross-trial comparisons should not be done. And as we can see, the palbo combination had median PFS of 44.3 months versus 29.1 months in only HER2 ET arm. Moving on, we have the HER2 Climb 05 trial, in which tucatinib was tried in the first-line metastatic breast setting. In the patients with confirmed HER2 positive metastatic breast cancer, no progression after 4 to 8 THP cycles, and no or asymptomatic brain mets were divided into tucatinib or placebo arm, with the primary endpoint being investigator-initiated PFS. And as we all know, there was significant PFS benefit with a difference of 8.6 months. And when we look at when it differentiated by hormone receptor status, we do see in the hormone positive patients the benefit for more nuanced with 12.3 months difference. Also, CNS PFS was done in these patients, and we can see doubling of the CNS PFS with adding tucatinib as first line. Moving on to the second line, there is no predominant CNS involvement patients. We have options like TDM1, TDXD, and LabCap available with us. And the patients with brain metastasis involvement, which is a common finding in clinics, with more than equal to 50% patients having brain mets when we diagnose them. In this, the HER2 Climb trial, in which tucatinib trastu with CAPE was used in previously treated HER2 positive metastatic breast cancer is there, in which there were two arms, in which one there was tucatinib with trastu CAPE, another with placebo. Brain mets were allowed, and as we can see, a significant patients, like 50% patient had brain mets, with 29% having an active brain mets. And the intracranial response difference was significant with 47 versus 20%. Also, there was significant OS benefit in the patients with brain mets, which was difference was around 9.1 months. And as we can all see with the patients with active brain mets, again, the CNS PFS was 5.4 month difference and OS was 8.7 month difference. And there was a new category, a new brain lesion-free survival measured in these patients. And we can see a difference of 13.8 versus 24.9 months in the patients who received tucatinib. And hence we can save patients' quality of life with the we have delayed the radiation therapy in these patients, hence improving the quality of life. Moving further to third line and beyond, there are no optimal sequencing methods, and it varies on case-to-case basis on the manner that the remaining options are used. And we have the option we all use, TUCA Trastuzumab Cape, if it was not previously used, with ORR of 40.8%. So when we look at the living ESMO MBC guidelines, we do see that in second and third line, if the patient have brain mets, TDXD, TDM1 remain an option, and with active brain mets, tucatinib is still an effective option. Similarly, in NCCN guidelines, HER2 positive patients having brain involvement, tucatinib Trastuzumab with CAPE remains a category 1 recommendation apart from TDXD. So with more accessible HER2 targeting therapies emerging, we can help more patients for better outcomes using Tucavo, tucatinib, Sigrima, pertuzumab, and Ujvira TDM1. So to conclude, access to anti-HER2 agents is currently increasing. Eligible patients should be brought under neoadjuvant first approach. TCHP regimen might be tweaked a bit. Positive long-term data of pertuzumab in adjuvant setting should be considered for patients, especially node-positive ones. And non-PET-CR patients should receive TDM1. And THP still remains the standard first-line care for HER2 positive metastatic breast cancer patients. And brain mets, tucatinib definitely has a role. Thank you.
Thank you, Rishabh, for this talk. So I think you are using these drugs about the PER2. So number of in neoadjuvant settings, use of PER2 along with this Trastuzumab. What do you think? Is it increasing? It is applicable? Is it worth?
Sir, it is definitely worth if PER2, especially when I have a patient with financial constraints. In the node positive patients, I definitely push the patient a bit for pertuzumab because it definitely has the benefit.
Yeah. Second part, the PET-CR. So regarding this regime, the PET-CR is increased or not?
The PET-CR is increased, and as we know, PET-CR in breast cancer, it definitely translates to overall survival.
So third point, if PET-CR is not achieved, then TDM1 is approach. Do you use routinely or do you continue with Trastuzumab with PER2?
Sir, I tend to use TDM1 if there is non-PET-CR.
Okay. And the next, the tucatinib. So I think, what do you think about this tucatinib? Nowadays, the options are exhausted. Patients are not affordable for TDM1. I think LAP and CAP option are going. So I think initially we are thinking about the LAP CAP option. So nowadays, tucatinib is available. So what do you think tucatinib in sequential? What sequence do you prefer?
Sir, if the patient does have active brain mets, earlier we didn't have the tucatinib option. It was too costly to use. Now, when we have it, definitely if a patient is having an active brain mets, we should go for tucatinib instead of WBRT upfront, because it saves the time of the radiation-induced side effects, the quality of life. Again, if TDXD is an option, it might be tried, but it is too expensive for a patient to buy. And tucatinib is a very good alternate option.
So what do you think about the tucatinib maintenance? So after the achieving in metastatic setting, the first line we have given that PER2, Trastuzumab, as well as carbopacli, as we have used 6 cycle, have given the patient have partial response. So do you want to put on the tucatinib maintenance in that scenario?
Yes, sir. If brain mets are there, I will definitely prefer
tucatinib. Without brain mets?
Without brain mets, I might not even consider, because the benefit we achieve with tucatinib is mostly that it crosses blood-brain barrier, which is not possible with trastuzumab. So it would be a bit tricky. If the patient can take and there are no side effects, then I might consider, otherwise no.
Yeah. So thank you, Dr. Rishabh, for this talk. Wonderful talk. So I think this is the last session of this webinar. So we concluded 2-day session. So I think yesterday we have discussed on this, the parameter of GI as well as GU, and the GI, GU, as well as the ovarian, as well as the endometrium cancer. And today completed the breast as well as the lung cancer. So I think, thank you all participants, speakers, my friends, as well as my seniors for participating in this event and giving your precious time for presenting this data. So I think nowadays the science is very, very well changing. Nowadays, initially we are focused on the conventional. Nowadays we focus on the precision based and newer technology, so that we are achieving the survival, OS, as well as PFS and better quality of life. So I think nowadays oncology are changing rapidly, dramatically. I think within 6 months, the newer things will happen and will adopt the practice. And the most successful thing is the introduction of biosimilars. So I think the cost of the therapies comes down, and more number of participants, more and more number of patients can benefited by these molecules, even if immunotherapy and even if targeted therapy. So I think the basket of these patients and targeted drugs, immunotherapies nowadays increasing with this biosimilar. So thank you all pharma companies and for sponsoring these sessions and guiding us. Thank you all participants. And last but least, thanks for the Tarun as well as the Pooja for making my job is very simpler form. So each and every part is coordination of speakers, timely management. And thank you Cancer Research and Statistics Foundation and SMDK Foundation for giving this platform. Thank you all and good night.
So thank you, Dr. Devesh, for giving this opportunity on behalf of my colleagues Pooja and Manya. It was a great experience. And till we meet again, from all of us from the organizing team, we say goodbye and good night till we meet again.
Good night.
Thank you. Thank you
Sorry,
so much.
Manya ka naam main bhul gaya. Sorry.
No problem.
Yeah.
So Pooja, so you can close.